Thank you, Love, for giving me an opportunity to speak in your instruction course on controversies in pediatric cataract surgery. Basically, this is an advanced course. Those who are doing pediatric cataract surgery, they will be appreciating more. Earlier age of IOL implantation in bilateral and unilateral cataracts. Pediatric management cataract targets are clear image formation on retina after cataract removal by an optical rehabilitation method which is uncomplicated, cost-effective, better patient compliant, and remains safe in long-term follow-up. That is the most important part we need to discuss, that what is safe in long-term follow-up. Because doing a pediatric cataract or implanting an IOL is not a problem. But whether it will remain safe in long-term, that is more important. That's the controversy. So pediatric cataract management option has three. It is primary IOL, it is aphakia with contact lens or spectacles, or secondary IOL implantation at a later stage. Deciding factors mainly are age of the child, unilateral or bilateral, level of understanding and cooperation of the parents, that is very important because their understanding, their affordability, everything guides your modality of treatment. Surgeon's own experience, that is also important, that over the years we are gaining experience who are doing pediatric cataract surgery. They have formed their opinion that what is to be done, and evidence-based medical literature. Because we have to depend on all this, because number of pediatric cataract surgeons are not much worldwide, those who are doing regularly, so we have to depend on the evidences, what others are saying. So what we know, as Love has introduced, 2 years, more than 2 years, IOL is accepted. Less than 7 months, not advisable IOL implantation by infant aphakia treatment study. And 7 months to 2 years is the gray zone. The controversy lies here. We are still undecided in the issues of primary IOL in infants because the anatomy of the infant eye is changing, it is not fixed. Up to 9 years of age, we have a critical period of visual development, and this is constantly changing. Basically, within 2 years, the maximum changes occur. So, infant eye is 40 to 50% smaller than adult eye, mean axial length 17 in infants and 23 to 24 millimeter in adult. Mean diameter of the crystalline lens is 6 millimeter. If you want to put an IOL in 1 month old child, so it will be around 6 to 7 millimeter crystalline lens or capsular diameter and at birth, and 9.3 at 16 years of age, and equator to equator capsular bag size is 7 millimeter at birth and 9 millimeter at 2 years of age. So anatomical changes in first 2 years. In first 3 months of life, lens power decreases approximately 4 diopters for term infant and 7.5 diopters for premature infants. Aphakic infants, the eye loses 4.4 diopters of hyperopia in first year of life and less thereafter. And axial length 16.5 millimeter at birth and 20.8 millimeter at 2 years, and next it is only 2 millimeter increase in 11 years. So calculating IOL power and putting a lens and what type of lens, all are very difficult below 2 years of age because of constant changing of the anatomy of the eye. Concerns at 1 year of age is the growth of the eye, accuracy of IOL formula, adverse events after surgery, and long-term follow-up. More than 2 years IOL is accepted because axial length is 80% of the adult size. First rapid infantile phase of visual development and maturation is complete by 2 years of age. The first initial phase of critical period is completed by 2 years, and IOL power calculation is more predictable. Older the child, less the postoperative inflammation, as our experience shows. So less than 7 months IOL implantation is not advisable by infant aphakia treatment study. So basically, I just highlight few points on infant aphakia treatment study because this is very important study. It was published in 2014. This is comparison of contact lens and intraocular lens correction of monoocular aphakia during infancy, a randomized clinical trial of HOTV optotype acuity at age 4.5 years and clinical findings at age of 5 years. This is over the period of time they have studied this, and there are many important findings in their studies. So eligibility criteria is monocular visually significant cataract less than 3 millimeter, more than 3 millimeter central opacity, age 28 days to 7 months at surgery, and willing to be randomized in both the type of studies. So what they said that they have demographic characteristic. Age is 4 months, 4 weeks, or that means 1 month to 3 months. Most of the patients are included in this. Contact lens and IOL, the same numbers they have included. So target post-operative refractive error holiday formula, 4 to 6 weeks they have kept plus 8 diopter, and 7 to 28 weeks they kept plus 6 diopter of the target refraction. And primary outcome at 12 months of age, grating acuity using Taylor acuity cards, and 4.5 years of age, optotype of HOTV test. So visual acuity treated eyes at the age of 4.5 years both have the almost same results with the contact lens and the IOL implanted. 2020 to 2040, in IOL group is less, in CL group is more. So major issue in cataract surgery in infants are the visual acuity, axial length or the myopic shift, post-op astigmatism, nystagmus and fixation related instabilities, cost, glaucoma and complications. So I'll give you some review of literatures on all these issues. A comparison of grating acuity, strabismus and reoperation outcomes among children with aphakia and pseudophakia after unilateral cataract surgery during first 6 months of life. This is one of the very senior surgeon who is doing pediatric cataract for Lambert, Scott Lambert. He has published this. So they said that although the mean grating visual acuity of the eyes undergoing primary IOL implantation was not significantly better than acuity of the eyes treated with contact lens, and similar incidence of strabismus among children undergoing primary IOL implantation compared with those who were treated with CL. So there's not much of difference in that. Visual acuity development after implantation of unilateral intraocular lens in infants and young children. They say that IOLs and phakic contact lens support similar visual acuity development in infants and young children treated for unilateral dense congenital cataract. Contact lens are the most common mode of phakic optical correction in infants because they generally are well tolerated and because the power of the phakic contact lens can be changed frequently, which IOL you cannot do that. So these are the observations. There are other articles other than IITS before that. They said that visual outcome and complication of bilateral cataract. This was a retrospective study. It was published in 2000. 13 children, 1 to 26 weeks, median 5 weeks. They have implanted IOLs, and 50% patients required posterior capsulotomy as a second procedure. And visual acuity also like this. And I would like you to notice this, that the maximum refractive shift noted in one patient was -9 diopter, -9 to 10 diopter. So there is a huge myopic shift if you put IOLs in the infants. And there is another study which says that 70% of the patients develop opacity, and complications are also noted in this study. In 2006 they have published. These are the few more literature. Retrospective analysis of children with dense bilateral cataract, BCVA 20/100 or worse in children operated less than 10 weeks of age. This is one important finding. The absence of preoperative nystagmus is better predictor of visual outcome than the age at surgery. So if you have a nystagmus at the age of what age you are doing, that is also important, the predictor of the ultimate gain of visual acuity. Axial length and myopic shift, this is also very important, that in 3 months of old baby, one IOL power of 28 to 30 diopter is required for emmetropia. However, this will lead to a significant myopia in later life, and the large myopic shift that occurs in the first 12 months of making IOL calculation even more challenging in cases of IOL in infants. Visual results of primary intraocular lens implantation and contact lens correction for aphakia in first year of life. That is, however, the eye is rapidly elongating during infancy, making it impossible to implant an IOL that will focus the eye during the immediate post-operative period and also after life. So there are a few studies which said how much is the myopic shift. Post-operative astigmatism, IATS has indicated one important finding, that significant less corneal astigmatism at the age 1 year examination of the eyes of the infants who underwent cataract surgery between ages 1 to 6 months and who were left aphakic and treated with contact lens. The reason they said that because of the changes due to the change of shape of the cornea due to the use of contact lens, that may be the reason. And nystagmus and fixation related instabilities also occurs. Nystagmus and related fixation instabilities following extraction of the unilateral infantile cataract in infants. It is also an IATS finding that we found a similar incidence of fixation instabilities in 2 treatment groups, like with CL also and the IOL also the same. So saccadic oscillation is also same in both the groups. Cost, IOL cost more in that age group. Glaucoma, incidence of glaucoma, the results suggest that glaucoma-related adverse events are common and increase between 1 and 5 years in infants after unilateral cataract removal at 1 to 6 months of age. Primary IOL placement does not mitigate the risk. Complications and intraoperative, there are huge amount of complications between children below 18 months of age. These are the complications, and these are all other findings. So I'm not going into detail because of the shortage of time. So there are 2 things, that contact lens correction in unilateral aphakia pros are the power can easily be changed as the eye grows. Secondary IOL can be implanted when the child is older than when the refractive error is stable. And the cons are that contact lens correction in unilateral aphakia, it is frequently lost, and there may be a delay in their placement, and ongoing maintenance is also difficult. And for IOLs, the intraocular lens correction of unilateral aphakia, the closely approximate optic of the crystalline lens, partial optical correction is guaranteed. So conclusion is that when operating on an infant younger than 7 months of age with an unilateral cataract, we recommend leaving the eye aphakic and focusing the eye with contact lens. Primary IOL implantation should be reserved for those infants where the option of the surgeon and the cost of handling the contact lens would be more burdensome. So with this, I say that is it worth effort of having just 20 by 30 visual acuity in 20%, orthoporia in 20%, and high-grade stereopsis 20% with IOLs. So it is better that in this group we go for more aphakia and contact lens rehabilitation. So thank you very much for your patient hearing.